Bacterial meningitis. Bacterial meningitis occurs when the bacteria that enter the bloodstream and travel to the brain and spinal cord cause acute bacterial meningitis. But it can also occur when bacteria directly infect the meninges. Bacterial meningitis caused by Streptococcus pneumoniae. This bacterium is the most common cause of bacterial meningitis in infants, young children, and adults. Neisseria meningitidis. This bacteria commonly cause an upper respiratory infection but can cause meningococcal meningitis when they enter the bloodstream. This is a highly contagious infection that affects mainly teenagers and young adults. Haemophilus influenzae. Haemophilus influenzae type B bacterium was once the leading cause of bacterial meningitis in children. Listeria monocytogenes. Pregnant women, newborns, older adults, and people with weakened immune system are more susceptible. Meningitis symptoms include sudden onset of fever, headache, and stiffness. There are often other symptoms such as nausea, vomiting, photophobia, and altered mental status. Newborns and babies may not have, or it may be difficult to notice the classic symptom state. Babies may be slow or inactive, be irritable, vomit, feed poorly, have bulging fontanelles, and have abnormal reflexes.
Epidemiology of meningitis. So as we can see, meningitis in Malaysia was last updated in 2018. According to the latest WHO data published in 2018, meningitis deaths in Malaysia reached 383 or 0.27% of total deaths. The age-adjusted death rate is 1.4 per 100,000 of population, ranks Malaysia, which is 81 in the world. Moreover, according to Ministry of Health Malaysia (KKM), there are 5 principal causes of death for infants. So the range age group is 0 to 2 years old. As you can see, the major principal causes of death for infants is 2019 and 2018, which is certain condition originating in the prenatal period, and this contributes 41.8% in 2018 while 42% in 2019. So then other following principles are congenital malformations, deformations, and chromosomal abnormalities. Then the third principle is pneumonia, followed by meningitis, and lastly is chronic lower respiratory diseases. Meningitis shows minor principal cause of death for infant in year 2018 and 2019, and it also contributes 0.8% in 2018 while 0.6% in 2019. As you can see in the figure 1, in 2019 there were about 371 total cases of meningococcal disease reported. So the figure 1 shows incident rates per 100,000 persons of meningococcal disease in the United States by year from 1970 to 2019. The incident rate began declining in 1995 and has remained low in 2019. According to the second figure, shows age group from 2010 to 2019. Anyone can get meningococcal disease, but rates of disease are highest in children younger than 1 year old, followed by a second peak in adolescents. Among adolescents and young adults, those 16 through 23 years old, have the highest rates of meningococcal disease?
Lumbar puncture. The patient should be seated position, bending forward or lying their side. The puncture site should be at L3, L4 or L4, L5. Draw a mark on the superior iliac crest that indicates the level of L4. Disinfect the area with 2% chlorhexidine plus 70% isopropyl alcohol. Inject 1% lignocaine for local anesthesia at the subcutaneous and slowly infiltrate deep layers. Then disinfect the skin again. Insert the spinal needle in the midline at 50 degrees upwards and never aspirate the spinal needle. Slowly insert the needle deeper and retract the needle introducer to see the fluid comes out. Feel the pop sound when it passes the dura. Collect the fluid in the recipient and do not collect more than 4 ml. Replace the introducer before removing the needle and slowly retract the needle. Lastly, cover the puncture site with an occlusive dressing and place the patient on the stretcher. CSF specimen. If the CSF specimen is less than 1 ml, it should be not centrifuged. Instead of that, the CSF should be plated directly onto the agar plate. If the collected CSF specimen is more than 1 ml, it must be centrifuged to sediment the bacteria. Centrifuge the specimen at 3000 rpm for 10 to 15 minutes. After the specimen has been centrifuged, the supernatant should be drawn off with a pasture pipette. Place 1 to 2 drops of sediment on the agar plate and smear preparation. Then incubate the agar plates in 37 degrees Celsius on 5% carbon dioxide.
Those are the things needed for the venipuncture procedure. Vacutainer or butterfly needle. 0.5% chlorhexidine gluconate in 70% isopropyl alcohol. Blood culture bottles. Tourniquet. Plastic apron. Sterile gloves. Sterile gauze or cotton ball. Gather all equipments and check the expiry date of the blood culture bottle. Introduce yourself to the patient. Check that the laboratory form matches the patient's identity. Perform hand hygiene. Open the dressing set. Arrange all the items including needle and gloves. Pour 0.5% chlorhexidine gluconate in 70% isopropyl alcohol. Remove caps from bottles and scrub the rubber bound surface of each bottle with separate alcohol swab. Perform hand hygiene. Position the patient comfortably. Extend the patient's arm and inspect the antecubital fossa. Locate a vein of good size that is visible, straight, and clear. Apply the tourniquet about 4 to 5 finger width above the venipuncture site and re-examine the vein. Perform hand hygiene and wear disposable plastic apron. Perform surgical hand rub. Wear sterile gloves. Clean the site with 0.5% chlorhexidine gluconate isopropyl alcohol by rubbing back and forth for 15 seconds and allow to air dry completely. Insert butterfly needle into selected vein. Enter the vein at 30-degree angle or less. Fill aerobic bottle first to ensure all air is removed from butterfly and tubing, then followed by anaerobic. Collect 10 ml into each bottle. Release tourniquet and remove needle. Discard the used needle into sharpening. Check the label and form. Do not cover the barcode on the bottles. Place in biohazard and send to laboratory with the request form.
Now, I will explain about the diagnostic test of meningitis. To identify meningitis, certain tests should be done to confirm the presence of meningitis in humans. Firstly is blood culture. This test is conducted with a blood sample is placed in a special dish to see the growth of microorganisms, particularly bacteria. A sample may also be placed on a slide and stained with gram stain, then studied under a microscope to see whether bacteria are present. Next is blood testing. A blood testing should be done to identify whether there is an increase in white blood cell count, which actually can indicate the presence of meningitis in humans. If transport to microbiology laboratory is not possible in the same day, place the blood culture bottle in an incubator at 35 to 37 degrees Celsius with 5% of carbon dioxide until transport is possible. The inoculated blood culture bottle should not be placed in the refrigerator. After being transferred to a laboratory for testing, examine the blood culture bottle for turbidity at 14 to 17 hours and then every day for up to 7 days. Any turbidity or lysis of erythrocyte may be indication of growth, and subcultures onto the primary culture media should be done immediately. Cultures should be done in agar plates to get isolated colonies. The type of media used are blood agar plate, chocolate agar plate, and also matte concave agar plate. After getting isolated colonies, a microscopic examination is done to get a presumptive identification on the basis of growth and colony morphology on a blood agar plate and chocolate agar plate, and also from a gram stain. Based on the results, for Neisseria meningitis, there is a growth in both chocolate and blood agar, and the gram stain shows a gram-negative diplococci. While for Streptococcus pneumoniae, it shows a growth in chocolate agar plate and also blood agar plate, and the gram stain shows a gram-positive diplococci. Lastly, for Haemophilus influenza, there is a growth in chocolate agar plate but no growth in blood agar plate, and gram stain shows a gram-negative philomorphic. For further confirmation about the presence of meningitis, spinal tap is done. Spinal tap is a procedure which is done using lumbar puncture. For a definitive diagnosis of meningitis, spinal tap is needed to collect cerebrospinal fluid, or also known as CSF. In people with meningitis, the CSF often shows a low sugar or glucose level, along with an increased white blood cell count and increased protein. CSF analysis may also help the doctor to identify which bacterium caused the meningitis. After CSF is collected, it is sent to microbiology laboratory to be tested. Firstly, psychological examination is done to identify typical CSF abnormalities associated with bacterial meningitis. Some of the criteria are turbidity, increased opening pressure, phagocytosis, decreased glucose concentration, and also increased protein concentration. Next, CSF culture media can be done to confirm the meningitis. Firstly, inoculate 1 to 5 drops of CSF directly onto both a blood agar plate and chocolate agar plate within 1 hour after collection. A backup broth is needed to inoculate with some of the sediment pellet. Example of backup broth used are brain art infusion broth with proper supplements. Agar plate and broth inoculate with CSF sediment should be incubated for 18 to 24 hours at 35 to 37 degrees Celsius with 5% of carbon dioxide. After isolation of colonies in culture media, CSF gram stain is performed. Gram-positive organism will appear dark violet or purple in color, while gram-negative organism will appear red or pink in color, which is from the counter stain. Figure 1 in the picture of gram stain of Neisseria meningitis in cerebrospinal fluid CSF with associated polymorphonuclear leukocyte is shown. Next, figure 2 shows a gram stain of Streptococcus pneumonia with white blood cells